So now we invite our first speaker on stage, Dr. Vivek Arya. Sir is a DM endocrinologist. He is an associate professor of endocrinology and a senior consultant at NHL Medical College and SVP Institute of Medical Sciences. He is also associated at the Center for Endocrine Disease and Diabetes. He is a great academician. May I invite on stage, sir?
Welcome everyone to this session, which is going to be more on all areas which are deficient in PCOS, and today we'll be starting with incretin, which is one of the new molecules which doctor will speak to us about.
Good morning, everybody. Thanks to PCOS Society, Dr. Kanti, Dr. Durusha, and the chairperson, Dr. Usha madam. I think we have a lot of old friends here to meet in this particular meeting. Now, the topic for today given to me is to talk about incretin. So before I start topic, I would like to know how many of you know about incretin in this particular hall. Please raise your hand who knows about incretin. All right. And who knows that there can be role of incretins in managing PCOS? Anybody? Oh, so except Manish, the hall is total this thing. So it is a big, probably very big task for me to take you through this particular topic, which is difficult and probably a very new topic to you people. So let's start. The story of incretins started long back. It dates back to 1930. When Barr described the greater effect of oral rather than parenteral glucose on increasing insulin secretion. And subsequently the work was done by Newak, and in that again suggested that glucose infusion to achieve a graded glucose level identical to those achieved with oral led to insulin response that was only 1/4 as great as that of IV. So subsequently, they found that probably why this is happening. When you give IV, response is not there, but when you give oral, response is there. So based on that, the incretin hormones were discovered by researchers, and it was named as incretin effect. Now let me explain you what is incretin effect. If you look at this particular slide, if you look at the blue line, that is when you give IV glucose, and this is a response of insulin. And the green line is when you give the same amount of glucose orally. The response of insulin is something like this. So what do you have in this? When you give oral, there is more insulin secretion, but if you give IV, the insulin secretion is less. And this particular effect is called as incretin effect. Now what are incretins basically? So when you take food goes to intestine, and intestine has a L cell which secretes two hormones, that is gastric inhibitory polypeptide and glucagon-like peptide 1, GLP-1. And these two hormones are basically called as incretin. And this incretin basically acts on the alpha cell and beta cells, and which basically helps in improving the glycemic status. Of these two, the more important one is glucagon-like peptide 1. So we will have more discussion on glucagon peptide 1 because time is limited. So glucagon peptide, it is again a 30 amino acid secreted from L cell, from ileum and colon. And GLP-1 receptors are present in islet cell and multiple other places like CNS system as well. GLP-1, it has been metabolized by enzyme called DPP4, dipeptyl peptidase 4 enzyme, which destroys this GLP-1 in our body. Now if you look at this particular slide, what I am trying to depict is the effect of GLP-1 at a different sites in the body. GLP-1 has effect at the level of your brain, where it decreases your appetite, increases your satiety. It has an effect at the level of your stomach and intestine, where it is decreasing gastric mobility and decreasing the gastric emptying. It has an effect at the level of muscle by increasing glucose uptake and glycogen synthesis is increased. It has an effect at the level of adipocyte, where there is increased fatty acid synthesis, increased lipolysis and increased glucose uptake. It has an effect at the level of liver, where it is reducing hepatic glucose production and decreasing glycogenolysis. It has an effect at the level of pancreas by increasing insulin secretion, improving beta cell survival and proliferation, decreasing glucagon secretion and increasing insulin synthesis. As well as it has an effect at the level of heart. It is a cardioprotective agent, decreasing the blood pressure and increasing myocardial contraction. So multiple effect, and all those receptors are present at all these particular sites, giving this beneficial effect. So as I said, the GLP-1, it enhances glucose dependent insulin secretion, inhibits glucagon secretion and therefore hepatic glucose output is reduced, slows down gastric emptying, increase satiety, so less food intake, and also help in stimulating insulin gene transcription and insulin synthesis. Along with this, animal studies have shown it increases beta cell, so decreasing beta cell apoptosis, stimulating growth of new beta cell, and probably it has been thought that in long term it can help in reversing your diabetes or progressive insulin deficiency can be reduced. This is the effect what happens when GLP is being injected to somebody. When GLP is injected, you can see the glucose levels are coming down. The blue line is when GLP is injected. The insulin level, you find it is rising, and you find that glucagon level, which is anti-insulin kind of a hormone, which is decreasing. So all this thing basically helps in improving your glycemic control in diabetes. Now what is the problem? When your body is there, body is producing GLP, then what is the problem? Problem is that unfortunately GLP, what body is producing, is broken down very shortly by DPP-4 enzyme. So which gives a very short half-life. DPP is produced, has effect, and it has been destroyed. But we want this particular chemical in much and much larger quantity so as to have a beneficial effect on heart, kidney, so many other organs. So what is the solution? There are two solutions. Solution number one, that we give something which is very similar to GLP-1. They are called as GLP agonist, or we can give some medicine which can block destruction of GLP-1, that is we give a DPP-4 enzyme inhibitors. So that enzyme can be blocked so that GLP is there in body for a longer duration of time. Now how does the story of GLP-1 started? Started with this particular animal, this is a Gila monster. And after the bite of this Gila monster, people used to get hypoglycemia, few people used to die also. So people thought that saliva of this particular animal has something which is causing hypoglycemia, and they found after that probably the saliva has something what is called as a GLP-1 like chemical. So this was subsequently found that first insulin, the GLP-1 receptor agonist was exenatide, and which has approximately 50% homology with GLP-1, and this binds to GLP-1 receptors and behaves like GLP. The advantage of this was that it was resistant to DPP-4 inactivation, the enzyme which breaks the natural GLP-1, but these analogs are not being broken by that particular enzyme. So it lasts in the blood for a longer time, and which became suitable for injection, and it was available as twice a day injection. So if you look at the homology between these two, almost you can say that the GLP-1 what body produces and the exenatide which had very much similar kind of nature. Now following exenatide which was to be given twice a day, there was lot many research were done to find out different kind of a GLP-1 analog. So after that there were analogs like lixisenatide which had a little longer duration of time, liraglutide which had again half-life was much longer than that, dulaglutide which has a half-life of almost 5 days, so which can be given once in a week, and you have a semaglutide which can again be given once in a week if it is given as an injectable, or it can be given oral, but it has to be given on a daily basis. So these are the different GLP-1 which are available as of now in the commercial market, which can be used in a different way. Now let's go to the topic of PCOS and what is the status of incretin, what happens to incretin. If you look at the continuous line and the black dots, you can see this is the effect of incretin. When given to a PCO patient, you find that insulin levels are higher as compared to the normals. And the GIP effect or GLP effect, what you see after giving this is much higher as compared to the controls. So what it was been found in PCOS that glucose level and insulin sensitivity did not differ in PCOS and the control group. PCOS significantly higher level of C-peptide, which we know because of insulin resistance. Total GIP was significant higher in PCOS as compared to control. Active GLP-1 level exhibited as a significantly different time-dependent pattern in PCOS. So the increase was much higher, but again, like GLP concentration, at an early phase reached significantly lower level in PCOS than control at 180 minutes. So almost coming down, it was being seen in PCOS patient. So this was a difference seen between control group and the PCOD group. Now let's talk about, do analogs, they have a place in treatment of PCOS? So these are the newer insights which suggest that if you give GLP-1, it is going to stimulate insulin production. So maybe the insulin resistance part or the hyperinsulinemia may get corrected with that. Suppression of glucagon secretion, which is anti-insulin, which will again be of useful. Delay in gastric emptying, satiety enhancement, hunger reduction, decrease energy intake, and regulation of appetite and food reward, which could be a beneficial effect in all such kind of cases. So different molecules have been used in PCOD. The one which was been used, and there are a wide number of studies which are available, are with liraglutide. And it has been seen when the liraglutide been used in PCOD patient, and we are expecting a weight loss of 5% or more. So in a PCOD, target is to have a weight loss of 5 to 10%, and if you are targeting 5% weight loss, with the liraglutide it was 46%, with the placebo it was 30%, and with orlistat it was 44%. BMI reduction of almost around 1 kilogram per meter square as compared to 0.1 with metformin. Low dose liraglutide, that is 1.2 milligram daily, plus metformin was found to be superior to metformin alone in increasing the IVF pregnancy rate. So these are very important take-home message. There are n number of studies, I have not enumerated all, but this is a take-home message that with the liraglutide you can have a good amount of weight loss in 76%, BMI reduction, as well as the small dose. In liraglutide, two type of doses have been used. This is a small dose, and the larger dose is 3 milligram, which is again been used but not tolerated by many people. How does it act? Probably the metformin we know, and probably I'm not going to discuss, but how liraglutide is going to act, basically it is going to act by reducing the visceral adipose tissue or obesity. It will have an effect at the level of pituitary as well as some direct effect on the ovaries. This is how everything is going to change using a liraglutide. And again, when it is in combination with metformin, again multiple effect on insulin resistance and decrease in the androgen will have a beneficial effect in PCOD patient. So the only weight, we thought that weight reduction is the only thing what is happening. But again, furthermore studies have been done, and in this slide to describe you like multiple effect. There's improvement in obesity, there is improvement in hyperinsulinemia, also there is improvement in hypothalamic pulsatility of GnRH, as well as there is a reduction in the hyperinsulinemia, SHBG. So multiple levels it may affect and may give a positive effect in PCOD patients. Now let's talk about the newer agent, that is a semaglutide, which is available. We have availability of oral as well as injectable. This is with the injectable in a small dose. The two doses are available, 1 milligram and 0.5 milligram. This is a small dose, 0.5 milligram per week, and you can see the BMI reduction from 34 to 29 in 6 months of time. Body weight reduction from 85 to 73, 12 kg weight loss in 6 months. Improvement in your fasting level, improvement in insulin, HOMA-IR. So all the significant improvements seen with semaglutide. So small dose, just 2 slides more, has effect to achieve reduce the body weight in almost 80% of obese PCOS patient unresponsive to lifestyle plan. They've already tried their lifestyle, not responding. It has been associated with normalization of menstrual cycle, best result in patient with mild obesity, improves insulin resistance and normalized glucose level. So to summarize, like the GLP-1, it has a multiple effect at multiple levels, improves insulin resistance, reduce body weight, reduce blood pressure, reduce blood lipids and reduces your blood sugar. So to conclude, though it has been secreted from intestine, it has a multiple receptor spread all over the body at multiple sites and has a beneficial effect. It has a potential role in PCOS. A significant weight loss and metabolic abnormality improves with GLP-1. The metformin plus GLP-1 receptor agonist gives the best response, and the obese PCOS patient with signs of insulin resistance, failure to lifestyle modification are the right candidate for GLP-1 analog therapy. Thank you.
Thank you very much, Dr. Vivek Arya. Actually, you have enlightened on a very dark topic to all of us, because when you asked everybody, there was hardly one Dr. Manish who knew. So, you should raise your hand then. Anyways, a fantastic lecture and very crisp and good take-home messages. I just wanted to know one thing. What are all the contraindications for giving this molecule, and also side effects? Yeah, correct. Yeah, my friends have even more questions, but then I also wanted to know what are really the complications if we give it, and how long can we give this molecule. So these are some practical questions that you could answer.
Sure, we'll take up all the questions. Number one, GLP-1 analog, they are available, easily available. Liraglutide is available, semaglutide, oral semaglutide is available, and by 2025 we will have injectable semaglutide also. Injectable semaglutide has much better response in terms of weight loss and other improvement as compared to oral. Oral also has fairly good effect. Cost, like liraglutide, now it is available at throwaway cost. Each injection now costs 2,000, which was costing 5,000 earlier. So you have much cheaper liraglutide which is available and which you can use in your practice. Semaglutide, we start with a smaller dose oral. We start with 3 milligram for a month, then you build up to 7 milligram, and then you go to 14 milligram. 3 milligram will cost around 10,000 in a month, and 7 milligram maybe 11,000, and 14 milligram maybe close to 12,000 per month. So that will be the cost of it. Side effect wise, the major side effect of GLP-1 is the nausea and vomiting are the main side effect, because lot many patients stop because they cannot, they have severe vomiting. Now, two things which are practically important is that number one, it reduces your appetite. So what people do is, when your appetite is reduced, you feel full but you still keep on eating. So then you will vomit out. So most important take home thing is, when somebody is on this particular, we always tell that when you feel full, don't eat anymore. You stop at that particular point of time. If you eat more, then you will vomit out. All the side effects are temporary for initial 5 days or 7 days. If somebody can tolerate, probably they will tolerate for a longer duration of time. Whenever we increase dose, again those symptoms will reappear, but again for 5-7 days they have to tolerate it and they can maintain that. Sometime we may have to down titrate also. If we increase and they are not tolerating at all, we go back to the smaller dose and we continue with the smaller dose for a long time. Other than that, there are not much of side effect other than this nausea, vomiting kind of a side effect. There are not much of side effect. Very important thing with this is that there were drugs like sibutramine, there were drugs like rimonabant, which was decreasing your appetite, and people had a suicidal tendency and people used to die. But this medicine gives you satiety with satisfaction. Nobody has that kind of dissatisfaction that I have not eaten adequate amount of food. So they have good satisfaction, so chances of suicide are almost negligible with this particular drug. So that is most important with most of the anti-obesity drug which has been used. Other than this, any question like those? Yeah. Contraindication like pregnancy is one of the contraindication which we, and in the particular age cutoff like we will not use it in children, it has not been approved. Below 12 years of age it has not been approved. So these are probably two, and people with a severe renal or liver dysfunction, these are the common contraindication. Otherwise it is a very good drug. It has to be used with caution and with knowledge. Yeah.
So,
Yes. Yes. So as I said, like the liraglutide and the semaglutide are two commonly used in drug. So liraglutide in the doses of 3 milligram per day has been advised for weight loss kind of a drug. The smaller dose of 0.6, 1.2 or 1.8 we use in a diabetic patient. But in PCOD study has been with a small dose, that is 1.2 milligram, and which were quite convincing to have a good benefit, and pregnancy rate was good with IVF with even a smaller dose of 1.2 milligram. So in a clinical practice 1.2 milligram can be used easily. Same thing with the semaglutide. The study has been with a smaller dose of 0.5 milligram, and again the results were pretty good. For a weight loss, a larger dose has been advised. Like for a weight loss, the dose of semaglutide is 2.4 milligram per week, which is Wegovy, which is available with the higher doses, and same thing 3 milligram of liraglutide, which was available, that was for weight loss. So it has been used as a weight loss drug in a higher, and for a diabetes or for other problem maybe in a smaller dose it has been used. Like for a higher dose, more chances of nausea, vomiting and those side effects are relatively more. For a smaller dose, those side effects are relatively less. Yeah, it can be continued. Normally to get any kind of response you should be ready to use the drug for at least 3 to 6 months. It can be continued, like there is long term data which is available for 2 to 3 years, people have used it. After that, when you get a good response, probably we can down titrate. Suppose somebody is on a higher dose, we can reduce a dose and we can have the similar kind of benefit with the GLP-1 analog. Of course, when they find that bariatric surgery has failed, they use this medicine. Supplementation? No. It is just like it is cutting down on your diet, and if your diet has a good amount of minerals and vitamins, and so no need for any kind of a supplementations. Yes, oral semaglutide is available. The only company is Novo, which is marketing with the name of Rybelsus. It has to be like with a caution. Probably somebody has pancreatitis, probably it has to be used with caution. Drug per se causing pancreatitis have not been, it is very much rare kind of a cases have been reported, but you have to be cautious. People having any kind of a pancreatic disease, either pancreatic cancer or chronic pancreatitis, it has to be with caution. With the thyroid cancer, again, like it increases the risk, but people having established cancer probably are not going to use it. But unless there's a family history or somebody has that kind of a genetic testing done, probably you are going to use it. Yeah.
I think from here we'd like a few questions for you, because we were waiting for the audience to ask all their questions.
Yes,
when we started using metformin, the biggest fear, mothers of little girls and all were worried that the sugars will drop, which didn't drop with the metformin. What happens to the sugar levels in these drugs?
Yeah, absolutely, because the secretion of insulin is glucose dependent. So once your glucose increases, the drug effect comes. If glucose do not increase, the effect like hypoglycemic effect will not come. So it controls the sugar. It is similar to metformin. Per se, this drug do not cause hypoglycemia. So a lot of non-diabetic patient, obese patient, this drug has been used. In fact, I have recently used this in one of patient who was supposed to undergo IVF, and she lost around 12 kgs of weight in 3 months with the Rybelsus, and now she is like probably from 108, now she is around 90.
Yeah.
So she has much better prospect for IVF, and chances of pregnancy are much higher.
But how many months before she starts her IVF she should stop the drug, or there's no need to stop? This is for
as
everyone
such,
to know.
as such, teratogenicity has not been reported, but there are no study to suggest. So normally it has been continued, and before they plan their ohm retraction or whatever, that time we stop it. But it gives a pretty good effect in terms of weight loss and make them
sure.
right candidate for.
Because there are some anti-androgens which we use for our patients in PCOS.
They
We
need to
say
stop
stop it 3 months before starting the therapy.
Yeah.
So whether this needs to be stopped
No, no,
3
no.
months before, because there'll be IVF experts here, it is important for them to
No,
know.
it do not have that kind of like anti-androgenic kind of side effects
Fair
are not
enough.
there. So it can.
Then,
So this is a very good input that you give, especially because there are a large number of infertility experts here. So how long would you like to give to attain a particular weight? How much time for this many kilo? Supposing 5 kilograms. So is it 3 months, 2 months? How do you?
Yeah, it is, see, the weight loss is totally dependent on patient. Like if you give whatever treatment but patient is not following lifestyle modification, not going to have a good effect. So with a good lifestyle modification, and when we use this particular kind of a drug, weight loss with semaglutide or liraglutide, it is person to person varying. There are people who have lost up to 20 kgs weight, and there are people who have not lost even 2 kgs of weight. So it varies from person to person, but definitely the satiety part is taken care of very well. There are a good number of our doctor friend also where I have started, and after starting they feel that I don't feel hungry much. The in between snacking has reduced. My overall, like I was eating 4 chapati, now I am full with 2 chapati. So automatically your calorie intake reduces, and if you are following a good lifestyle, definitely you are going to have a good weight loss. But what people do, if they take a lot of fried item, they take a lot of sugar, then probably they may not lose weight. So those dietary restriction plus medicine is definitely going to give a good result.
I just wanted to ask you one thing. GLP-1 and leptin, are they related? Because
No.
leptin also has a similar function that it increases
Yeah.
the satiety levels and
Yeah. So leptin is a separate hormone and GLP-1 is a separate hormone. Leptin is been researched, like adiponectin and leptin, they have been researched. They have a very similar kind of effect. But leptin or leptin related analog which has not come into the commercial market, it is just part of the research. They find that leptin levels are high, or you have a leptin resistance. When you have obesity in PCO, you'll find a high leptin levels. So leptin resistance kind of thing is seen, but it is not like a therapeutic part of leptin has not been described.
thank you.
combination with metformin.
Yes. As I suggested that the study with the liraglutide and metformin, if only metformin used, only liraglutide used, the response was less. But when the metformin and liraglutide combination, like 1.2 milligram of liraglutide with metformin 1000 milligram been used, the response was much better. So it is ideally a good combination to use metformin along with liraglutide kind of a drug, which gives probably a better, because they are targeting different pathophysiology and overall giving a very good response.
And used after food, before food, or with food?
Yeah, it has to be taken once in a day. Probably before food is a better time to take this drug. So before food.
So I think if there are no more questions, thank you very much, doctor. And it's been a very good session, and that's the best part of our PCOS meetings. We always keep a lot of time for discussion.